my name is Kinley Calloway. I'm a student here at the University of South Alabama. Today I'll be performing my NG tube insertion and discontinuation. I would like to preface this video by saying that I'm very hoarse and very sick. I'm going to try to talk as loud as possible to verbalize everything that is needed. So to begin, I would be verifying my patient order. We have an order for insert Salem sump and connect to low intermittent wall suction. I will verify my patient using two identifiers. We have Jaguar J. Jones. His date of birth is 8/25/1963. 8/25/1963. He has an allergy to penicillin and an allergy to penicillin. I will perform hand hygiene. I would explain the procedure to the patient. Mr. Jones, I'm going to be performing a nasogastric tube insertion today. It's going to be a tube down your nostril and into your stomach, and it shouldn't take very long. It might be a little bit uncomfortable, but it will be over soon. I would raise the bed to a working height and lower the side rail and raise the head of the bed to a high Fowler's position. All of my equipment is in front of me. I have two pairs of clean gloves, my 60 milliliter syringe, my goggles, my basin, my towel, alcohol prep pads. This is going to be used as my tongue blade. I have my pulse oximetry, a cup of water for my patient, and my Salem sump, and I have my tape pre-prepared for my patient today. I will don my goggles, and with the tube insertion, I would discontinue if the patient's vital signs dropped or changed in any way, if the pulse oximetry dropped, and if the patient experienced respiratory distress. I will begin by assessing my patient's vital signs with my stethoscope and examining their abdominal bowel sounds. And I would do so assessing if this is on an actual patient. For now, I will keep my stethoscope in my pocket. I will go ahead and I'm going to place my towel on my patient's chest, along with the basin for any emesis and for the tubing. With my tubing, I will demonstrate in another video how I would measure my patient's tubing from the nose to the ear to the xiphoid process on an actual person. For now, I will open this. And I would have water-soluble lubricant on my packaging to lubricate the tubing. And I would also, with the measurements, I would mark a ending spot on the tubing. For now, I will just do one for an example for this connection procedure. Actually, I need to use the tape with the doggy ears, which I have here. So I will prime my tubing for 4 inches and place this here. I would, according to hospital policy, clean the bridge of the nose with soap and water or with an alcohol prep pad. To decide which nair it would go in, I would ask the patient to close one nostril and breathe, and close the other and breathe. And I will establish a cueing sign with my patient, indicating if I needed to stop. Today our cueing sign would be this. So the tubing has been primed, and I would encourage the patient to swallow as I'm inserting or drink water if necessary. I will begin inserting the tubing, and I will go at a twisting angle, going 180 degrees as I insert 1 to 2 inches, and I would stop if the patient used our cueing sign, if they were experiencing any signs of respiratory distress, or if they began to cough, or if their vital signs changed and the pulse oximetry dropped. Once I hit the nasopharynx and go beyond that point, I would have the patient extend their head forward, but before that point, I would ask the patient to extend their head backwards. And if the patient were to experience any of the symptoms of respiratory distress, I would stop the procedure, pull back into the nasopharynx, and continue whenever normal breathing had continued. Without letting go of my tubing, I will secure the tube to the patient's cheek temporarily. And I would take my tongue blade and my pen light and put in the back of their mouth to determine correct tubing placement. Once correct placement has been determined, I would prep the skin with an alcohol prep pad and secure it using the floating method either to the bridge of the nose or the cheek. And I would check for, it says for 3 signs of correct tubing placement by aspirating for gastric contents, assessing the pH, or if necessary, any x-rays. So there are 2 ways in which we can do this. We would either cap the tubing as demonstrated or connect to low intermittent suctioning, which would be back here. It would be connected here. Excuse me. I would keep the blue pigtail above the patient's stomach, and we're using the capping method, so I'm going to cap that today. Okay, and I would then take another piece of tape, which I did accidentally grab earlier, but I would place it on the bridge of the patient's nose, and it would be labeled with the date and time. And then I would clean up all of my supplies. Remove my gloves, my goggles, and perform hand hygiene. I would lower the head of the bed to no lower than 30 degrees, raise the side rail, and lower the bed to the lowest height, and go document the procedure. I would document the type and size of the NG tube we used to Salem sump, the location as in the right or left near, the time, any characteristics, colors, amount of secretions noted, how it was secured, how well it was secured as well, and how the patient tolerated the procedure. And I would perform sorry, that was my next one, the discontinuing. So now I will demonstrate how I would discontinue an NG tube. I would also have my towel laid out here, and I would have my gloves. I would first verify the order on the hospital sheet, the patient chart, and verify my patient using 2 identifiers. I will perform hand hygiene and don my goggles and my gloves. And I would disconnect from suctioning if suctioning was used. I would, which I just realized I did not note in my previous video, there should be a marking with an inedible marker, noting any displacement of the NG tube so that we can note that in this video. And I would also have clipped my tubing to my patient gown and allow them to be able to turn their head according to hospital policy. And I would also, I'm so sorry, I'm completely losing my voice in this video. I would also, as in the previous video, assess their vital signs and auscultate their bowel sounds, noting any change in the pulse oximetry. So to begin, I would remove the old tape. And be sure that I've kinked the tube and pull back slowly and gently. And clean the nose with an alcohol prep pad or soap and water or skin prep, whichever according to hospital policy. And I would then lower the bed to the lowest position, raise the side rails, and check on my patient, place any call light, personal belongings that they need in reach. Remove my gloves, my goggles, perform oral care, perform oral care and document my procedure, any amount, color, consistency of secretions, and how my patient did. And that concludes my NG tube insertion and discontinuation.